Thank you, sir. You're live.
Good evening, everybody. On behalf of Cardiological Society of India National Body and the Cardiological Society of India Chennai Chapter, I welcome you all on the third day of this Cardiac Rhythm Council annual meeting. It's my privilege to have the luminaries in the field of cardiac electrophysiology today speaking and moderating and coordinating with the session. And I invite now Dr. Aparna Jaswal, one of the most accomplished electrophysiologists in the country, who is the co-director of Department of Electrophysiology at the Escorts Fortis Hospital. May I invite Dr. Aparna Jaswal to take over the first session.
Thank you so much, Dr. Ulhas. At the outset, I'd like to compliment you for what a wonderful meeting we're having with such a large footprint where we haven't seen people in such numbers attending this meeting and the way it has been orchestrated. Today, it is great honor and pride for me to be introducing to you none other than Dr. Ulhas himself. Why I say that is I think those of us who are actively involved in electrophysiology do owe a lot to him for having conducted several of such meetings, and they truly have been of great benefit to one and all. Dr. Ulhas is the chief cardiac electrophysiologist at Madras Medical Mission. He's had his postdoctoral electrophysiology training from Milwaukee University of Wisconsin, as well as University of California from San Francisco. He's the founder president of Tamil Nadu Electrophysiology Council. He has been the past president of Indian Society of Electrocardiology. He has had several awards to his credit, and one of which is of great repute, Dr. D.P. Basu Memorial Award for his original work at the CSI Cochin. He has had the Young Cardiologist Award at the CSI conference in 1998, and of course, the Best Doctor Award by Dr. Tamil Nadu MGR Medical University of 2013. So as the saying goes that teaching is a work of heart, but I think for Dr. Ulhas, it doesn't end there. Teaching for him is a work of art as well as a work of heart. So I leave it for him to take on this wonderful topic, which is of great interest, especially in the COVID times. Over to you.
Hey, hi, Aparna. Thank you so very much. So kind words. And good evening, everybody. And the co-moderators for this session, K. Chandrasekhar, the senior electrophysiologist of Chennai City, Dr. Ajit Thachil, who doesn't know him, one of the best minds in the field of cardiac electrophysiology in the country. It's my privilege to be speaking to all of you today, the third day of the digital summit on remote monitoring issues. Very basic points regarding the remote monitoring is the theme of my topics, to make it more popular and why it should be made popular. That's going to be my theme or a motto of this talk. And I would like to begin by saying that over the last 2 decades, the advancement in pacemaker technology has been so tremendous. They have become remarkably smaller. However, their ability to function precisely has increased significantly. In addition, they are able to store a huge amount of digital data pertaining to their function, pertaining to the patient's native rhythm. They also store so much of a digital information, for example, the indirect measures of cardiac hemodynamics, maybe even some measures regarding the physical activity of the patients, and several such more. Since all these data are stored electronically, they can easily be transferred to, for example, a receiver. And that receiver, which receives these information electronically, can in this present era be transferred wirelessly, seamlessly over the internet to the physician, even when the patient is at a remote place. This is essentially what I consider is the definition of the remote monitoring of pacemaker or any implantable electronic devices are about. So essentially, the pacemakers or the defibrillator or any implantable electronic device has this ability to transfer the data that is stored electronically to a receiver, and those receiver can be of a different shapes and sizes. And these receivers over the last 10 years have become so very small that the receivers can be as small as a smartphone, or the smartphones themselves are now acting like the receivers. The technology by which the device transmits the data, maybe it differs from company to company, maybe RF data transmission or Bluetooth. But the point here is there is this seamless transfer of the data, which is electronically stored here, to be sent to the receiver, which is really very small. And this transmission can happen with or without participation of the patient. It may happen on scheduled basis, or the latest generation of these receivers are such that all 24/7 the transmission of the data takes place without any participation by the patient. Once these gadgets receive the data, they automatically, without further participation from the patient, are transmitted over the internet to a central service center or a data server. No actually human participation in this. It is just a site where it is stored, and till such time it is all encrypted. It's only when it goes to the licensed practitioner that this all could be decoded and the information would be read very securely by the physician. This is the so-called mechanism by which the digital data is transferred to the physician or his colleague. Now the question is why this is required. People, we're doing quite well with the pacemakers, but why remote monitoring? But the question is why at all even a pacemaker interrogation in the clinic? Because most often the pacemaker clinic visit by the patient, I believe it is a useless exercise. Most often there are no actions taken because the devices are quite technologically advanced. The expertise to deal with the pacemaker functioning is increasing. The physician knows how exactly you need to be, programming the device. What are the parameters you could be set? All that is done at the time of the implant and at the time of the discharge. And hence, it appears most often the pacemaker clinic visits are simply the waste of the medical resources and so much of a discomfort to the patient because he had to travel a long distance many a times. And at the clinic, there is this waiting time, could be frustrating, and the cost that is involved with respect to the travel and the physician's fees and the fees even at the pacemaker's clinic. So in general, most often pacemaker clinic visits are not really necessary, and hence a pacemaker functionality could be actually assessed through the remote monitoring. And there's another important reason why remote monitoring. There is every reason to make the patient feel better, or the patient should feel that it was worth he underwent the device implantation. Presently, it appears that we are not doing a great service to our patients without the remote monitoring, and with the remote monitoring, the data that is being transmitted, if we make use of the incoming data from the patient, maybe we can actually provide a better care to our patients. So these are the two important reasons we should go through why we should consider remote monitoring. The question is, how is the quality of the data that is transmitted? There is some kind of a concern. If that all comes, how is this data? I would like to show a piece of paper here. This is the kind of a transmitted data, which is so very clear. It is probably looking much, much clearer, much better, and you can go through every single detail what you could have otherwise done in your pacemaker clinic. So that the data that is transmitted it's as good, but if you ask me, actually I feel it's much better because you are at the comfort of your office, on your computer or in your smartphone. You actually are looking at it, unlike you getting into the pacemaker clinic and looking at, on those programmers. So the data that is transmitted, I think it is as good or better than what is there in the pacemaker clinic. Another important thing, if you start looking at the remote monitored patients' data, you can actually do a nice follow-up data of these patients, which is really tough to do it without the remote monitoring and at the pacemaker clinic. Here, everything is systematically stored, and you can actually see how your patients have been doing. For example, this is one screenshot which I taken few years back. At just one glance, I would know how many patients are into that group, what could have been the reasons for the implantation, how they have been doing, and many kinds of statistical assessments or research you can do, which is really very tough without this kind of a data that is available to you. It is also possible to make you aware of what is happening to the patients if you are looking at some specific alerts. You probably are interested to look at, say, for example, how many PVCs this patient is having. And if you think it exceeds a particular number, you would like to get an alert. Well, you can adjust. You think he is at risk of developing a stroke, and then you would like to really know the high atrial rate events and their duration, etc. If you think you need to be alerted if this guy is having this more frequently and for a longer time, you can make that kind of atrial rate monitoring as an alert. There are so many things. So you can customize what kind of an alert you would like to have, apart from, in general, all the information which the pacemaker is able to transmit. So this is another interesting thing. Specifically in a particular patient, you may actually look at the performance of the lead, for example. You have an apprehension that one of the insulation is an issue, or maybe the pacing thresholds are an issue. So that you could monitor much more keenly before he becomes symptomatic or before there occurs an event. The question is all right, whether it actually helps, apart from all this, actually helps in reducing the mortality, say, not necessarily in ordinary pacemakers, for example, some kind of a bradyarrhythmia, congenital complete heart block, structurally normal heart. We almost are certain that he would do well. But we are talking about the remote monitoring of some complex devices like CRTs and defibrillators. How is it possible that the remote monitoring does help? If you look at the timeline of a patient or the clinical course of a patient with an implantable device, typically, say, for example, CRT or a defibrillator, when you follow him up after the implant, there comes a time, most often, a time when they may require hospitalization for worsening of the heart failure. There comes a time for an inappropriate shock. He visits you. There may be appropriate shock. There can come a time when there is this VT storm, or there is a time when he's admitted for a stroke. Maybe patient comes, dead, or maybe there is an occasion suddenly you feel there is a battery depletion. So these are all the hard endpoints, which anyway a patient with the implantable device, if you follow up. See, when you have these hard endpoints striking at one particular time, what is important to understand is these hard events are the culmination of the events which are taking place before this point. there were, for example, some arrhythmia events which were taking place. For example, high atrial rate events or atrial fibrillation. It was going on here. It was unrecognized, and he developed stroke. Maybe the by-V percentage was not very optimal, and it had led to worsening of the heart failure or hospitalization. Maybe the impedance strengths are not great, and then there's a lead malfunction, and then the patient dies with a sudden cardiac death because there was this lead malfunction. There have been ATPs, which is indicating that the patient may get some kind of a VT storm. So all these hard endpoints can be avoided if we look at what are the events which are taking place even when the patient is not around you. So this, I believe, is one of the major reasons why remote monitoring is respected. And this is the fact which should make us believe that the remote monitoring should be recommended. So the proactive treatment is possible with remote monitoring because you are going to be proactively treating some of these events which ultimately culminate into a hard endpoint. So it is possible that you not only increase the quality of life, but by remote monitoring, you probably increase the survival of your patients with the implantable devices. All right, this appeared to be theory. What is actually the evidence? Where is this hard data to say that it actually improved the quality of life, it increased the battery longevity, and most importantly, where is this data that the mortality is also less with remote monitoring? If you look at the published literature regarding remote monitoring in the last 10 to 15 years, there is an ample evidence to say that the quality of life is better, battery longevity is longer, and including some other hard endpoints like admission for hospitalization and survival benefits. All right, so now all this, has it led to any recommendations by the guidelines, typically by the apex bodies of cardiac rhythm and heart failure management bodies? Well, I would like to say that all these societies or the bodies who recommend the arrhythmia therapies and the heart failure therapies unanimously have recommended very strongly with a kind of a class 1A category of recommendation for remote monitoring. All these bodies insist that remote monitoring should be an integral part of your implantable device program. I was convinced about remote monitoring, and our center is one of the early centers to adopt this technology way back in 2009 when it was just then introduced. When it was introduced, we really went behind this technology because we really believed that it is a great technology. But then it appeared to us that it takes a lot of time. It requires so much of an infrastructure, and ultimately we could get from the administration really a nice infrastructure and then some dedicated people, me and my colleague and 2 or 3 paramedics who are dedicated to that. But over the period of time, the technology has improved so significantly that presently we do not really have truly a kind of an infrastructure saying that this is a pacemaker clinic, etc. It's like there's no separate space. Everybody has their gadget and simple a laptop or a smartphone. So it is as simple as that. Well, of course, it cannot be run by a single person. For example, an implanter cannot run the pacemaker clinic. He has to be ably assisted by his colleague who could be also an implanter, and essentially 1 or 2 paramedical force. Without this team of 4 members, I do not think this is possible. So there indeed is a requirement for an infrastructure, but not as much as it was, say, for example, 10 years back. The technology has made this whole remote monitoring issue a simple task, that I can tell. I hear in the recent times, some of the implanters are also outsourcing the so-called remote monitoring service. My strong opinion about this is that I would like to remind that this is not a recommended strategy. You need to have your own team. Outsourced remote monitoring management is not going to translate into a better care. The outsourced information is like another alert. So you need to be looking at more closely and not an outsourced result. You need to have, essentially, I would like to say that the infrastructure can be very minimalistic. There has to be, of course, an active participation, preferably by 4 people in a center. Time to time, we have been publishing our results. For example, from 2009, when it was just about 50, we have been, showing our results in almost all the major conferences of arrhythmia and heart failure, and we always are showing that it is feasible. The compliance by the patient is good, and we have so far had very, very positive response from the patients, and we are very positive that this remote monitoring is actually helping our patients. Some challenges which I would like to go through very quickly, and those challenges are the cost and the preparedness and the belief of the physician and his team in this technology. I talked about some infrastructure, and of course there are certain legalities are involved, and that the questions related with these kind of legalities could be what should the physician do exactly when an alert is received, and what should be an appropriate response time. Well, this particular thing is not answered even in any one of the documents, but I think one needs to be alert when you have taken up this responsibility. In case if there is a mortality and a morbidity, and that is typically could be attributed to an event, and that is missed by the remote monitoring people. So what it could be, and what are the data confidentiality, and then is it okay to reassure the patient over the phone number? Is it a good practice? See, there are many legalities that are definitely involved here. There's no clear-cut answer to this, but I think it is the way you have communicated with your patient that you indeed are going to be taken care. If that assurance is you are ably giving it to your patient, and your patient believes in that, I think it is okay. But one thing is certain, there is going to be a paper where the patient has written it very clearly. You have taken an informed consent that this remote monitoring is not an emergency service. As long as this is very clear to the physician, he shouldn't be worried about any legalities. And as long as this is signed with on an informed consent by the physician, I do not think if there is a missed alert, or if there is a morbidity or a mortality because of a missed alert, you are going to be dragged to the court. And in fact, across the globe, there had been no serious legal issues. No physician or a group has been dragged into the court for some compensation because an alert was missed. So at the end, I would like to say that remote monitoring is such a great tool. Whether your patient is active, whether he's outside your clinic, whether he's at home or anywhere, he can really participate in his activities. He can be really very active with confidence. And of course, even when he goes to sleep, he can be very sure that his physician and his team are actually observing what is going on with his system through the remote monitoring. So I think it's a great tool. Patients feel really quite assured and confident, and then the physician, because he has recommended this, actually he will be more confident in treating his patients better. With these words, I would like to conclude my talk.
Thank you so much, Dr. Ulhas. That was
Ulhas,
fantastic.
it was a great talk. Rakesh Yadav here. Hello.
Yeah, so Aparna, I think you can take over first, and then I think Rakesh was coming.
Okay, so I think Dr. Ulhas, that was a fantastic talk, and I'd like Dr. Ajit to take over from now because there are some questions in the chat, Dr. Ajit.
Yeah, the chat.
Yeah, if you...
I can't see.
Yeah, Aparna, I think you can...
I'll push the questions to you for the want of time. So there's a question by Dr. RD that are you able to program these devices remotely?
Yes. At this point in time, even though it is feasible, it is not recommended. So we are not authorized to do any kind of active adjustment of the parameters remotely. And I think it's presently at this stage, it's quite safe. Till such time, we are very, very confident about, not bringing any harm to the patient, either me or indirectly by somebody. So actively, you cannot reprogram of the parameters. However, what you can program is the way the data is transmitted to you. You can make a particular alert changed. You may make a particular frequency of alert transmission. You can change things like that. But you cannot reprogram the parameters.
I think one very important point which has come up is, would you like to comment upon the battery life of the device in remote monitoring?
Absolutely. You see what happens typically. This is a great question, especially in this particular environment. See, we all are looking at our his bundle, things, and we are always putting up high outputs and things like that. There are ways of even looking at the thresholds very, very scientifically, not necessarily what it actually is showing. You can actually look at the QRS morphology and things like that. So, especially in this COVID environment, especially with the his bundle technology, I believe this remote monitoring has helped to even tweak. For example, if we think that 1 month is there was a good follow-up, we used to call them later, So now we can actually make them to come earlier, or it's possible to make somebody to go to his place and then adjust, of course with our thing. So it is possible to look at the threshold trends and then you can adjust. And then there are issues about unnecessary shocks you could have done. So that also could be such that if you avoid some shocks, you are looking at the trends of the arrhythmia, and you can reprogram and then increase the longevity. You can avoid the shocks. You can avoid, for example, even ATPs. But just these two things.
We are trying to come. Just one question.
Yes.
Hello.
Yes, go ahead.
We are trying to cover medical legal issue in this, but we have not at all highlighted or touched upon this. I think that will be going to become a major problem in our country.
Okay, Aparna, did you hear his statement? I could not hear properly.
Yeah, what Dr. Rakesh Yadav commented is about the potential medical legal issues, which I think you already made a reasonable statement on that there could be potential issues, but so far there have been none, and I think beyond that, at this point, we cannot say anything more. Right. That there could be issues, but so far there have been none.
Rakesh, I think you are one of the legal minds in the field of medicine. Great question. See, I don't know whether you saw a particular slide. You see, as long as you have taken an informed consent from the patient that remote monitoring is not an emergency service, it has taken care of so many things. At the most, the alert has been missed, and there's a direct evidence that the alert was missed, and then there caused the mortality or there occurred a morbidity. But then you are taking that this is not like one of those emergency services. So this is what is protecting you from the legal suits.
So, Dr. just one quick question on Can you comment on what is the patient input required for this? It's slightly different for different devices. For example, the Medtronic versus the Biotronic. Can you just comment on what the patient needs to do?
Absolutely, absolutely. You know what? I think the technology, every single company, they are bringing in technological advancements. For example, the latest one is from the Abbott. For example, it's a Bluetooth technology, where the patient does not have to have any receiver, special receiver. It is his smartphone is the receiver, and then he just has to keep his mobile phone charged. That's all, and there is a direct and automatic communication. There is no active participation at all. However, if you look at some other devices where there's an active participation, especially for the basic, for example, the old generation pacemakers, for example, patient needed to have almost like as big a tool as a programmer at his home. He had to put that thing on the wand, and then there was the transmission. So we have all generation of the devices presently. The participation by the patient is becoming less and less. And now I think most of the devices are going to be enabled in such a way that there is a seamless and zero participation on the patient for the transmission.
Ullas,
Yes.
excellent talk, and especially more useful during this COVID pandemic period, avoiding the unnecessary visit to the hospital. And I got one query that is out of curiosity. What is the PaceArt Optima system?
Yeah, you know what you were saying about OptiWall system?
No. PaceArt Optima system, Optima. That is, they have mentioned as one-stop scheduling integration with the CareLink network. Is there anything such thing exists?
No. If you think you know something about it, why don't you quickly tell us? Because the terminology varies from
No. Actually, I read somewhere PaceArt Optima system. It is a one-stop scheduling integration with the CareLink network.
I mean, talk about Azure, the new Azure link which has come with Bluetooth from Medtronic.
Yeah. I don't know. I'm just asking Ullas that.
No, it's okay. I've
not heard that term.
Ullas, we use Optima PaceArt, so I can share.
Go ahead, tell us something about it.
So it's not as seamless as you think, but it is basically a warehouse where when you perform any interrogations of your patient, the data automatically gets into the Optima warehouse system, and you can link that to any type of electronic health records. So if your office, it really helps out your office staff who has to go through all the remote transmissions. So this is pretty much a touchless system where your remote transmissions and your manual pacemaker interrogations go into a data warehouse, which then integrates with electronic health records and helps you schedule patients, review transmissions, review interrogations without any manual contact.
Perfect. So I think, these are all the additional benefits of all this, so-called digital technology. The research becomes much easier with this kind of an integration. These are the other benefits of the remote monitoring. So Aparna, let me tell you that I'm actually honored that you took over the session, Ajit and Chandra. Thank you very, very much. So that is the end of the first session. We have something very interesting coming up here. And this talk is going to be by Dr. Shomu Boda and Dr. Rakesh Yadav. Rakesh Yadav is going to be, taking over and introduce Shomu Boda and his topic. Rakesh, are you around? Rakesh may not be around. He just was around here. He was supposedly to be taking over. In the interest of the time, let me introduce Dr. Shomu. As I was telling earlier, he is one of the very senior and experienced electrophysiologists coming from the state of Gujarat. Known for his academic works, he had been in the editorial positions of the major journals coming from India. And he has consented to talk on ECG markers for sudden cardiac death. I welcome Dr. Shomo, and Shomo, you can start sharing your screen, please.
So, very good evening to all. Dr. Ullas, it has been a pleasure to be here in this very widely attended conference. Respected chairpersons, you have given me a very difficult topic, ECG markers of sudden cardiac arrest, to be completed in 15 minutes. And what I would say is, when you are talking about the risk, what you see the risk is one that we see in ECG, but there are a host of other risks like echo, functional class of the patient, the etiology of the problem, the genetics, and so on and so forth. So what my topic would be that I will just give you a ECG based risk, but then you have to have that correlation with other risk factors and don't only go on to the ECG for that. The scope of this is so vast, so I'm not including arrhythmias, not including acute ischemia, not including Holter or other special markers in this, hence limiting ECG risk assessment to non-urgent settings for this topic. We all know that patients who have, so a normal routine patient who comes in, if we want to assess sudden cardiac arrest, the reasons are basically cardiomyopathies, coronary artery disease, infections, and channelopathies more. So how do you assess the risk? The risk of an ECG would be based on STT changes, bundle branch block, PVCs, ECG hypertrophy, QT interval, T wave changes, QRS duration, and P wave. And we'll discuss in details based on various examples. So I'd like to have this topic in 3 different parts. When you have an ECG with an abnormal echo, which may be MI or non-MI, you have an ECG with a normal echo, but the patient has some symptoms like syncope, exertional symptoms, or family history of sudden cardiac arrest. And the third category would be patients who have no symptoms, so those who have been screened and the echo is normal and no family history. So we'll see examples of all the 3. So coming on to the first part, ECG changes and history of prior MI, not acute MI, prior MI. And this is an old MI. So when you have a patient with old MI, what do you see in this ECG? What you see here is the QRS is broad. It's in left bundle branch block. The PR is prolonged and there is a notched QRS in most of the leads. And what about a recent MI where there is no chest pain? What do you see immediately? You see is Q waves. So there are Q waves with poor R wave progression in V5, V6. You have a QT which is prolonged, and you have persistent ST elevation with T wave inversion present. So in MI, old MI or a recent MI, what are the risk features and what is the importance? The fragmented QRS, the bundle branch block. Now, in an acute MI setting, the right bundle branch block is actually more risky than left bundle branch block. But in a chronic setting, it may be the opposite. If you have a wider QRS more than 120 millisecond, you have persistent ST elevation, you have QT prolongation, T wave inversions, Q waves are there in more number of leads. When you have poor R wave progression, or you have a positivity in AVR, meaning like an abnormal QRST angle, these are all high risk features of having sudden cardiac arrest. The approach in MI or a structural heart disease is to do an echo, and actually echo the most important risk factor for sudden cardiac arrest, and the ejection fraction of less than 35% with symptoms or less than 30% without symptoms are more important. You need to get a coronary angiography done for reversibility, a Holter maybe, and the device therapy is primarily based on the echo finding, not on the ECG finding. However, if you're doing a device for primary prevention and you need more justice to do a device for primary prevention, you can add on the ECG findings like a wide QRS or non-sustained VT or multiple VPCs that are there on a Holter. But then based on ECG, there's no device therapy that is done. What about patients with non-MI structural heart disease, which include cardiomyopathies and myocarditis, especially when you see such patients in clinical practice? This is an example of such patients. What you are seeing here in this ECG is a low voltage limb leads and a high voltage chest leads, which is classical of a cardiomyopathy situation. Here you can see the PR is prolonged, there is late atrial enlargement, and there is a late transition. So classical of a cardiomyopathy. This another ECG of a patient where there is LVH with strain pattern suggests that there is some kind of hypertrophy, maybe HCM, maybe AS, or maybe even chronic long-standing hypertension. This is another ECG showing fractionated QRS, wide QRS. If you think of ARVC epsilon waves, there are significant STT changes in all of the leads, and that may signify any cardiomyopathy, RV cardiomyopathy especially.
Ashoma, sorry to bother you. Is there any noise around you?
No.
Absolutely fine.
Yeah.
There's so much of a noise coming here. All right. Okay, you can carry on.
Sure. This is a patient who has acute symptoms, and then you have seen that the ejection fraction is low, and then this patient presented with acute myocarditis. And if you see here, there is presence of bundle branch block, Q waves in 2-3 AVF, there are STT changes, and there is sinus tachycardia. So in a patient who is acutely ill, sinus tachycardia itself is a higher risk feature, saying that the patient has decompensated. So risk factor in non-ischemic cardiomyopathies that we have discussed: low voltage complexes, conduction abnormalities, atrial enlargement, poor airway progression, strain patterns, wide QRS, fractionated QRS, STT changes are significant risk factors. So overall in structural heart disease, what do you find is very low voltages complexes, which suggests less myocardium biventricular involvement. Low voltage in presence of hypertrophy is actually much more risk, saying that there is more of fibrosis, and you have a broad QRS with axis shift, suggesting that there is conduction or peripheral abnormalities or scarring. So this is an example of low voltage complexes in a patient who had this kind of very thin myocardium, biventricular involvement, hardly contracting myocardium, or a patient with HCM. If you find that there is absence of LV forces and a fractionated QRS, it's more of actually what you call as a fibrotic or towards going into end stage hypertrophic cardiomyopathy. This gentleman had very wide QRS complexes, so the presence of a wide complex, atrial enlargement and PR prolongation with a very wide LBBB suggests higher risk in such patients. So how do you score this? So Strauss et al. Used a QRS scoring system using the Q, R and S wave amplitudes, duration and notches in 10 of the 12 standard, that is except V1 and AVR, and it identified and quantified scars in ischemic and non-ischemic cardiomyopathy and concluded that patients who had a low score had actually less arrhythmias and less sudden cardiac death, and with a high score had more arrhythmias and more sudden cardiac arrest. Now going into the other important part of the discussion, the ECG in symptomatic patients for syncope or palpitations when the echo is normal. The family history is very important, and symptoms of on exertion, syncope or palpitations are very important. So this is the first example, a 29-year-old patient with history of palpitations. And what do you see in this patient, this ECG? There's a short PR, delta wave and QRS which is wide. This suggests obviously WPW ECG. So what are the high-risk features of even a WPW ECG? If you have a posterior pathway, if you have multiple pathways, and if the pre-excitation remains at higher heart rates, or if the patient has syncope on history. Low risk may be because of intermittent pre-excitation, if you call that, but still it is a matter of debate. However, if you have WPW, it is probably higher risk than a normal population. On to channelopathies, this is a 14-year-old boy with his history of exertional syncope, and what you see here is QT prolongation. QT prolongation is one of the higher risk that we see. The higher the QT prolongation, the higher the chances of having sudden cardiac arrest. And Dr. Moli, I would definitely talk further. This is another patient who had sinus bradycardia along with QT, which is prolonged, and there is notching of the T waves, which suggests more advanced possible problems. And the last in the part would be T wave alternance presenting in a patient. You can see that this is negative T wave and positive T wave in V1, which suggests that the repolarization is actually much more haphazard going around in this patient. These patients may come with torsades, definitely. The opposite of long QT being short QT. So if you have a short QT, and the higher risk features in short QT would be presence of atrial fibrillation and ventricular arrhythmia. So that patients are at high risk of sudden cardiac arrest. What about Brugada syndrome? If you have type 1 Brugada characterized by 2 millimeter ST elevation from the baseline and then an inverted T wave, along with symptoms, that's very important, along with symptoms that suggest high risk. In the absence of symptoms is a matter of debate, and then induction, maybe testing is much more important as compared to the ECG alone. We get so many patients, young patients with history of pre-syncope, and you find that these patients have a VPC, but then you have mild, what we call as a Che point elevation, and then you think that it is early repolarization abnormality. Now, in early repolarization abnormality, an elevated takeoff of the ST segment is basically what is early repolarization, seen more in the lateral leads or the mid-precordial leads. However, if you see more in the inferior leads as compared to the lateral leads, and the elevation is more than 2 millimeter after 80 milliseconds, if there is a down-sloping ST segment rather than an upsloping, then these are high-risk features. So if you have just early repolarization, but then early repolarization, if it is more than 2 millimeters downsloping as compared to upsloping and more in the inferior leads, they are at higher risk. Patients may come with normal ECG at rest, but if you make them exercise, they may go into arrhythmias, and this is a classical of CPVT. So there may be ECGs which are done on exercise. This classically, if there are VPCs which increase on exercise, and that is when you may say that these patients are at higher risk rather than anything else. So in a patient who has symptoms or a family history with a normal echo, these are the subgroups: long QT, Brugada, short QT, early polarization, and some unidentified, in which you may need to do a cardiac MRI rather than an echo also to know that these are early HCM or ARVC among the others. The last and the most challenging category of risk stratification would be patients who have just screened their ECG. They have no symptoms, no family history, echo is normal. The risk stratification may include TMT, Holter, drug challenge, genetic testing, cardiac MRI, and so on and so forth. But then you need to tell based on ECG whether they need to do further anything. And this is one example where there are mild STT changes present. Now, if you see this, the STT changes are in the T wave inversions and mild ST dropping down. So T wave inversions in infralateral leads or mild increase in Q waves, which may not be significant, but then otherwise a normal ECG. So these patients may be totally asymptomatic towards normal ECG. How do you risk stratify them? So I got one study which actually looked onto various criteria in a normal population, how to see them. So there were various criteria like QRS duration over 110 milliseconds, QRS T angle of more than 100 degrees, QT interval which is more than 440 men and 460 in females, left ventricular hypertrophy, early repolarization, and T wave inversions which are more than 1 millimeter deep others than AVR. And what they found out in 10 years, if they see in univariate and multivariate, they were
I'm extremely
significant.
sorry for the interruption, sir. There is 2 minutes of your screen time left for the presentation.
It is
Thank
finishing.
you.
It's finishing.
Thank you, sir.
So normal ECG, if you see this, the risk is less, but if you have more than one ECG abnormality, at 15 years and 30 years, there is significant difference in the difference between a normal ECG. So if you see the p-value, one ECG change at 15 years, it may not be as significant as more than two ECG changes, but at 30 years, if you have even one ECG change, the p-value comes to be significant. So the rationale was QRS duration 10 milliseconds prolonging increases the cardiovascular risk by around 18%. And QTC abnormality that we have seen, LVH may signify fibrosis and arrhythmia, and T-wave inversions may be the first sign of a hypertrophic cardiomyopathy. So other markers may be late transition in E5, P wave abnormalities, which includes interatrial blocks, or deep terminal P wave, which is there in V1. There is some role of AI in ECG. The ECG of normal patients are fed. The AI recognizes the patterns. Future maybe get your ECG scan done. The smart machine gets into it and the type report is there. So this is done by various calculations. The AI sees this, associates with the database, and then it gives you the output. So there have been various studies, various trials which have actually seen how the risk stratification works, and future maybe the machine checks it, the ECG's machine goes, then it says that don't be silly, your ECG is okay, you don't have risk of sudden cardiac arrest, or you may be saying that you don't have much time. So that may be the future. Concluding ECG in relation to symptoms, disease diagnosis, echo finding, and family history is very important. ECG criteria of sudden cardiac death are non-specific in structural heart disease patients. ECG criteria in channelopathy patients may be more specific, but in general population, you need to see based on symptoms, echo, and other abnormalities. Thank you so much.
To comment, the moderator for this session, K. Tamil Selvan, to comment. And I also invite Dr. Suchit, to comment on this. Now that we do not have Rakesh and Nanda Kumar, they will chip in. Dr. Tamil Selvan and Dr. Suchit to moderate, to ask some questions or make some opinions.
Hello, sir. I'm audible?
Yes, you are.
Okay. So, sir, beautiful presentation by Shomu, sir. I just want to know one thing, that EF as a means a predictor of a sudden cardiac death, or it is more, it makes sudden cardiac arrest more intolerable. That I just want to know. I mean, sometimes does it precipitate arrest, or is it that it makes intolerable the VT or something like that?
Yeah, it works both ways. In fact, the presence of structural heart disease and the EF being low is a risk of sudden cardiac arrest. And having any arrhythmias, be it VT or be it even SVT, the patient will tolerate it less. So both ways it works.
Okay.
Overall, it is a very nice presentation.
Thank you.
So thank you, Dr. Tamil Selvan.
Overall, it is a nice presentation. I have a specific question to him, sir.
Yeah.
In patients, in the subset of patients with atrial fibrillation, there is always a risk of pre-excited AF, which can be potentially a lethal condition. There is a way to predict. In some subset of patients can go for a pre-excited AF. That is also a very good ECG marker for sudden cardiac death.
Right.
When the short RR and RR interval is less than 250 milliseconds, that predicts well. And apart from the routine parameters discussed, some of the ECG findings could be useful in predicting sudden cardiac death, like the presence of S wave in lead 1, that in patients with ECG finding like Brugada or Brugada-like pattern. That is a very good marker for predicting sudden cardiac death. Apart from that, there is also possibility of P wave abnormalities, interatrial block. That also can be useful to predict sudden cardiac death. U wave inversion. That is also. In case of T wave alternance, you also look for the discordant T wave alternance or concordant T wave alternance. Discordant T wave alternance most often predicts sudden cardiac death. And overall, it is a very nice presentation, sir. Thank you.
Right, thanks.
All right, so Dr. Shomu, wonderful as usual. The traces were fantastic. All your traces, I'm sure, how meticulously, how collected. Great.
That's according to your guidance. Thanks.
Shomu, thanks very much.
Thanks.
John, welcome. John Roshan is a professor in Vellore Medical Center in the famous Vellore, CMC Vellore. He's my friend. He leads the Department of Electrophysiology and Pacing at CMC Vellore. Quite an accomplished electrophysiologist. Now over to John Roshan to welcome Maulisha and the co-moderators with you. Over to John Roshan for the third talk of today's session. John, you are not audible. Still not audible, John. So somebody should help John. John, you should unmute your mic, please. Still, I can't hear. I think there is some.
Good evening, Dr. John. So there is an option of share screen under your Zoom app. Can you please click on it and make sure that the computer audio is on?
All right. Anyway, I think before he sets in, let me actually take this honor of introducing Dr. Molly Shah. In the electrophysiology community in India, well, she's a very well-known figure. Those cardiologists, who are not into the electrophysiology, let me tell you that it is such an honor for Cardiology Society of India to have such an accomplished electrophysiologist who has made so much name in US, and she heads the department of cardiac electrophysiology there. And the program of electrophysiology in Madras Medical Mission was actually initiated by her. And I always take pride in saying that the standards were set by her, and it seems like MMM today is doing some good work in EP is all because the path is set by Dr. Molly Shah. John Roshan, your mic is set. You may have to say some words. John is still not around. So Molly, I think there is some technical glitch from John Roshan's side. It's a privilege to have you, and you please initiate your talk.
Well, thank you so much. That was quite an introduction. I don't think I can take all the credit for the great work that's been done at the Madras Medical Mission, but it was an absolute honor to work with you there. And thank you for inviting me to give this presentation. Again, it's an absolute honor every time I get asked to speak at one of the electrophysiology conferences organized by the Indian Electrophysiology Society. So my talk today is a little bit different than the other presentations. This is not a didactic talk. It is a case-based talk, and I hope it will generate good discussions. So Ulhas asked me to talk about or present 2 cases of long QT syndrome. And as you know, I am primarily a pediatric electrophysiologist. So we're going to rewind to the very beginning of the spectrum in the age group of long QT syndrome. So case 1 is a baby girl born to a 28-year-old lady. This is her first baby. The child was born at 36 weeks gestation and was delivered by C-section because the mother had preeclampsia. The child was born with a birth weight of 2.1 kilos. There's no family history of sudden death or known cardiac arrhythmias, but we know that both parents have mental illnesses. This mother did undergo evaluation for fetal irregular heart rate. And before we go on to the case, I just want to share some of the fetal echocardiographic features. The first fetal echo was done at 28 weeks of gestation because the obstetrician was concerned about an irregular heart rate. And as you can see at 28 weeks of gestation, this fetus is in 2-to-1 heart block. So as you can see on the M mode, we have an atrial rate of 120 beats a minute and a ventricular rate of 60 beats per minute. The fetal echocardiogram was repeated at 30 weeks of gestation. At that time, the obstetrician was not sure if this was fetal heart block, meaning congenital complete heart block, or whether there was another pathology. And as you can see in this fetal echocardiogram on the M mode image, we now have a ventricular rate that's quite fast. So this fetus is now having salvos of ventricular tachycardia. In addition, the fetus also had biventricular dysfunction, a small pericardial effusion, but there was no hydrops, so they decided to continue the pregnancy. Now, with this knowledge, and we can discuss this at the end of my presentation, should the obstetrician have contacted a cardiologist, and should there have been transplacental treatment? Well, the baby is now born, and the baby was transferred to our neonatal intensive care unit, and the first EKG at birth is as follows. As you can see, the patient is actually in normal sinus rhythm. We don't see any evidence of 2-to-1 AV block. And what is striking is that there is a wide QRS with a left bundle branch block pattern, and the QTC is very prolonged at 680 milliseconds. So even if you take into account the wide QRS, we still have a very long QTC interval. Now, we've all been taught that in long QT syndrome, we can predict the genotype by looking at the EKG. So for example, in long QT1, the EKG shows early onset broad-based T waves. In long QT2, we see low amplitude and bifid T waves. And in long QT3, we see long isoelectric ST segments with late appearing T waves. So let's go back and look at this EKG. Can anyone predict what the genotype here is? And if you can, maybe you want to just post your answer on the chat, and we can look at the results later. So as we're getting the baby settled into the neonatal ICU, the telemetry is now showing that the baby is bradycardic and is, as you can see on the top panel, has 2-to-1 AV block. And as you can see in the bottom panel, now the baby is having episodes of
You're going to put the curtain, is it?
Here we are able to get an EKG, and as you can see, the patient has 2-to-1 AV block. And if you look at the arrow, which I thought was an interesting QRS complex to show, we now have an Ashman beat. So we have long, short intervals with an Ashman beat followed by episodes of torsade. So what are our treatment options? Most likely the ICU attending is going to call their cardiologist or the electrophysiologist, depending on who is present. Our treatment options at this time are pacing, defibrillation, or medical management. Now we have an unstable neonate who is barely 1 hour in age. Pacing is going to be very difficult because the child needs to have some hemodynamic stability to undergo a surgical procedure. Defibrillation is, of course, possible with the risk of an electrical storm. And we now have our main option, which is medical management. So what is the first antiarrhythmic treatment for this neonate with long QT syndrome, 2-to-1 AV block, and recurrent torsade? So at this point, we started an IV esmolol infusion. This is a routine practice for babies who are nil by mouth. The esmolol infusion was titrated up to 250 mg per kilo per minute with no effect. We had recurrent torsade. The patient was also started on intravenous lidocaine, and the patient was given multiple boluses of intravenous magnesium sulfate. So I always like to keep this slide in mind, that whenever we're called to the ICU, we always go in with a plan. And as Mike Tyson said, everyone has a plan till they get punched in the mouth. And this is our punch in the mouth, that no matter what drugs we gave to this baby, we had the same result: intermittent 2-to-1 AV block and recurrent torsade de pointe. So what is our next step? So as you know, in long QT syndrome, isoproterenol infusion can be used in selected cases for VT storms. However, remember, isoproterenol actually increases the IKS current through adrenergic stimulation and may increase early after depolarizations and the risk of torsade. But if this patient had long QT syndrome type 2, while isoproterenol increases the IKS current, it actually compensates for the reduced IKR current, which is the defect in long QT syndrome type 2. By increasing the IKS, it may accelerate repolarization, shorten the QT interval, and can actually reduce early after depolarizations. So why not? We started the patient on an isoproterenol infusion. Remember, we're still in the first couple of hours of life. We have absolutely no idea what the genotype of this patient is. Torsade de Pointe continues. What is our next strategy? Well, some of you might be too young to remember that phenytoin is actually an antiarrhythmic medication. We now think of it as an anti-seizure medication, and it works on the neural cells and the brain channels just as it does on the cardiac channels. Phenytoin is actually a class 1B agent. It inhibits the rapid inward sodium and L-type calcium currents, and anecdotally, it has been effective in long QT type 3. Again, we don't know what this patient's genotype is at this time. We know that phenytoin prevents early after depolarizations and has been used in the treatment of torsade de Pointe, irrespective of the cause. So we loaded our patient with intravenous phenytoin, and magically, the arrhythmia resolved. Does this patient have long QT3? Is phenytoin the silver bullet for this patient? Well, the arrhythmia resolved for about 12 hours. It did give us enough stability that we were able to keep the patient in a stable hemodynamic state. However, remember, the patient is in the ICU. And with long QT syndrome, there are external triggers. So we know that with long QT1, the external trigger is exertion, emotion. With long QT2, the patient is susceptible to auditory triggers. And with long QT3, rest or sleep is a trigger for torsade de Pointe. Our patient is in the ICU. The ICU is full of auditory triggers. So every time an alarm went off, our patient went into torsade. Every time another patient's alarm went off, the patient went into torsade. So our next step in stabilizing this infant was to put on noise-canceling earmuffs. And this worked immensely well for the next few hours. This is a noise-canceling earmuff that is made especially for neonates to keep them quiet and rested in the neonatal ICU. And for the next few hours, while shutting off all the auditory triggers, the patient had another few hours of stability. However, arrhythmias continued, and in the next 24 hours, the patient received 17 ICD shocks. We're 1 day of age, and we haven't been able to get this patient out of torsade. So day of life number 2, how do we keep this patient alive? What is our next step? Well, we did have a few hours of hemodynamic stability. Our surgeons are extremely adept at placing bedside temporary epicardial wires. We didn't have to take the patient to the operating room. And as you can see, the patient had a period of quiescence with temporary ventricular pacing. However, again, after 12 hours, arrhythmias continued. By this time, the patient had reduced ventricular function, poor urine output, poor perfusion, and recurrent arrhythmias. So what do we do now? The patient also continued to have ventricular tachycardia despite pacing. So our next step was to put the patient on ECMO. And as you can see here, this baby now has temporary pacing wires. We have had the surgeons cannulate the neck for the ECMO cannulae, and we're resting the baby on ECMO. The baby continues to have periods of torsades, but without any adverse hemodynamic consequences. However, as you know, ECMO is not a permanent strategy, and we need an exit strategy for ECMO. We have now exhausted all the antiarrhythmic medications that we have. We have put in temporary pacing wires. The patient is being paced and continues to have torsade. So our next step here is to perform a left cardiac sympathetic denervation procedure. And as you know, this can be done either surgically or through a video-assisted thoracoscopic procedure. This child is only 2.1 kilos, so a VATS procedure is out of question. This would be the first baby reported in the literature who had an LCSD performed on ECMO. I will not go through all the challenges of performing this procedure on ECMO, but one of the challenges is positioning the patient. The patient has to be in a lateral decubitus position for a sympathectomy, and you can just imagine with cannulae coming out of the neck how difficult this is to even position the baby in the right direction. For those of you familiar or not familiar with this procedure, it's extremely important for the electrophysiologist, the cardiologist, to be intimately involved with the surgeon when this procedure is being done. This could come out to be a sham procedure if it's not done properly. Therefore, it's imperative that the surgeon removes the ganglionic chain, which includes the lower half of the stellate ganglion, as well as the ganglia from T1 to T4 or T5, and all the major rami communications.
I am extremely sorry for the interruption, ma'am. There is 2 minutes of your screen time left. Thank you.
Thank you. So as you can see, the surgeon has to be extremely diligent about cutting off the nerve connections. And as you can see in the lower panel, we are now showing you the sympathetic chain that has been excised. We typically send it for immediate pathology so that the pathologist can identify that all 5 ganglia are removed, after which the surgeon can now close the chest. This can alternatively be done in adult patients with a simple stellate ganglion catheter block, but this effect is very temporary. Post left cardiac sympathectomy, this patient was completely arrhythmia-free. The patient continued to have 2-to-1 block and even 3rd-degree AV block. We placed a permanent pacemaker. The patient has had no arrhythmias. The patient has been treated with propranolol and mixolydian and is arrhythmia-free for the next 1 year. We'll talk about the genotype of this patient in a second. I just want to point out that irrespective of what the genotype is, in extreme cases of long QT syndrome, mixolydian is an extremely useful adjunct treatment to a beta blocker. This is our discharge EKG on this patient. The QTC has now shortened to 550 milliseconds. And let's just talk about the genetics before I end this presentation. As you know, there are 17 genes associated with long QT syndrome as of 2020, but 3 main genes account for 75% of all cases of long QT syndrome. In this patient, we finally got genetic testing results back at 6 weeks of age, and the patient was positive for a KCNH2 mutation, which is long QT type 2. In addition, the patient also had variants of unknown significance in an additional gene, and this is the TRPM4. Before we go to TRMP4, I want to talk a little bit about this potassium channel. It's really important to understand not just the type of gene mutation, but also where it is located. Suffice it to say that any gene mutation located in the poor region where the arrow is pointing to is the most detrimental type of mutation. We now have data that gene mutations dependent on the location and the type of mutation predict long-term risk. So this patient had a missense mutation in the poor region of the potassium channel, therefore adjudicating the highest risk of all types of long QT type 2. Finally, was this really a case of the usual functional 2-to-1 AV block? Now remember, our patient when first presented did have 2-to-1 AV block, but also had a wide QRS and left bundle branch block. We hypothesized that the additional variant of unknown significance in the transient receptor potential melastinin 4 gene, this has been implicated in pathogenic variants that are associated with cardiac conduction disorders, familial progressive AV block and Brugada syndrome, and it is ubiquitous in the Purkinje fibers. And therefore, we believe that in addition to the functional type of 2-to-1 AV block, this child is also predisposed to permanent AV block because of this variant of unknown significance. And with that, I'm going to end my talk and open it up to questions.
Thank you, Dr. Mauli. That was an awesome talk and a great case. And sorry about the technical glitch I had earlier and being unable to have the privilege of introducing you. I think you very comprehensively covered that very interesting case, and I'm glad I haven't faced that kind of nightmare so far. But just a problem that we face quite often is because we've got a large number of deliveries in our hospital and a very well developed nursery. We quite often see babies with QT prolongation in the range of between 490 to 530, and it particularly when it's clubbed with a history of poor obstetric history where the previous sibling had died suddenly and nobody's sure about what's happened. We are not sure how to take things forward because we do the genetics and it comes back showing variants of unknown significance. And should we keep these people on beta blockers? How long would you recommend we follow them up? I was just wanting some clarity on that.
Sure. Thank you, John. So very quickly, I think in long QT syndrome, the data has shown that family history is not predictive of sudden cardiac death in the proband that you are treating. And therefore, the treatment should be directed at the phenotype of the patient that you're treating and not at the family history. So if your patient has had a family history of sudden cardiac death, but the QTC is 430 milliseconds and you're unable to get genetic testing and you don't know what the cause of sudden cardiac death is, we typically will not treat those patients. We might follow them for a few years. When these patients are old enough to perform an exercise stress test, and we can talk about that, I think it's an excellent way to provoke concealed long QT syndrome. On the other hand, if you have a patient whose QTC is 500, and whether there's a history of family history of sudden cardiac death or not, by all means, that patient needs to be treated. So any patient who has a QTC over 470 in males and 480 milliseconds in females, with or without family history, we will treat them with lifelong beta blockers.
Thank you. Thank you. I don't see any questions on the chat, Dr. Ullas.
Suchit can give his comments.
One thing I want to just ask, madam. For example, fetal bradycardia can be a manifestation of a long QT syndrome of the fetus. Now, what is the threshold to start fetal therapy in case of long QT syndrome in the child? What is the threshold? When do you start?
That's an excellent question, and that's why I didn't answer it in my presentation. So in our case, the reason the obstetrician, after consultation with the cardiologist, did not start any kind of fetal therapy at that time was because the fetus was already intermittently bradycardic. So that's that's a clinical decision we have to make. So fetuses typically, as you know from fetuses with congenital heart block, even at the rate of 50 beats per minute, they are very healthy in utero. So we should not necessarily be afraid of fetal bradycardia to start transplacental treatment. In this child, considering that there was already evidence of in utero torsade, I think it would have been reasonable to start transplacental therapy. However, in infants who just simply have 2 to 1 AV block, are growing well with no other evidence of tachyarrhythmias, I don't think they need transplacental treatment.
Thank you.
Yeah, Suchit, can you read a question from Dr. Yash Lokandawal?
Okay, sir has asked that in India should be doing many more cardiac sympathetic denervation procedures for long QT syndrome. Sir has written, we have been doing bilateral T1 to T4. There is some controversy whether it should be left only or bilateral. So he is asking whether it should be left only or bilateral.
Yeah, so it's a great question, Yash. I am a big proponent of cardiac sympathectomy for long QT syndrome. I think in these extreme cases, it should really almost be thought of simultaneously with medication and devices. As you can see in our patient, we didn't, even though the patient had so many VT storms, we did not put in a defibrillator, even though it was technically possible. And just the sympathectomy made all the difference. So I really think that in a case like this, as soon as you stabilize the patient, in this case, we had to put the patient on ECMO to do anything. So ECMO actually allowed us to do the sympathectomy because we wouldn't have been able to do it without ECMO. Sympathectomy should be the first line of treatment in extreme cases. My personal experience is that left cardiac sympathectomy is most likely to work. When it doesn't work, we have also done bilateral, but those bilateral sympathectomy, if left doesn't work, it's less likely that bilateral is going to work, if that makes any sense.
Another question has come. Is a brief general anesthesia useful strategy to arrest refractory VT storm?
Yeah, so it is. And that's what this patient was completely anesthetized, paralyzed. But you have to really make sure you're not using anesthetic agents such as sevoflurane, which prolong the QT interval. So make sure you talk to your anesthesiologist. The role of the electrophysiologist in managing long QT syndrome is to be in constant communication with every individual who touches the patient. You don't want this patient to be getting sevoflurane, but keeping the child quiet and paralyzed, anesthetized is definitely recommended. We did it in this case, but it didn't work.
Ma'am, hi, I have a question. Whether a patient with long QT syndrome in pregnancy, they actually portend a higher risk only in the postpartum period. Could you please explain it, ma'am?
Yeah, so can I know I didn't show you my multiple choice questions, but I want to just share my screen for 1 second, if it's okay, Ulas. I know we're probably short of time.
It's okay. I think it should be possible. If it's technically it's easy, I think
it's going to be possible. So here is, can you see my screen?
Perfect. We can see.
All right. So one of the MCQ questions I had is long QT syndrome type 2 females are considered at highest risk in the postpartum period, and it is really related to hormonal changes. So does anyone want to answer this question? A, increased estrogen. B, increased progesterone. C, increased HCG. So the reason the highest risk is in the early postpartum period is because of high estrogen levels. In fact, progesterone is your friend. So in the postpartum period, if at all possible, if you have a high-risk patient, you should try and consider giving them progesterone, because increased estrogen levels are the reason that these patients are at risk.
Thank you, ma'am. And in atrial fibrillation, to assess the QTC, whether we need to take the QT interval or we have to look into T-wave morphology, which is more pertinent?
That's a tough one. So, I think any kind of rate correction you do in atrial fibrillation is going to be irrelevant. So the T-wave morphology matters. And what we typically do is measure the QTC with the shortest RR and the longest RR, and then average it out. But that's difficult to do.
Thank you, ma'am. In a patient with widened QRS, whether JT interval is of more importance?
Yes, so we measure a JTC. So just to give you a cutoff value, in patients up to the age of 21 years, we have actually measured the JTC values in long QT syndrome patient, and a cutoff of 340 milliseconds is useful to be significant for long QT syndrome with a wide QRS. So just remember 340 milliseconds.
Thank you, ma'am. Thank you so much.
All right. So thank you very, very much, Molly, and all the faculty who were moderating this session. And John Roshan, Suchit.
Thank you.
Thank you very, very much. It was an honor.
Thank you, sir.
Thank you very much,
Yes, we are going to the last of the talks of the today's session. And it is by Dr. Malini Madhavan, one of the most accomplished electrophysiologists faculty at Mayo Clinic. And this particular session is going to be moderated by Dr. Deepak Padmanabhan, another rising star in the field of electrophysiology in the country. I'm so very proud of his work. Dr. Deepak Padmanabhan is going to be ably assisted in moderation by my own hero in my own institute, Dr. Sivakumar. He is another accomplished cardiologist, pediatric interventional cardiologist. His knowledge about EP is amazing, and he is directly involved in managing several of the long QT syndromes. And of course, we have another senior interventional cardiologist, Dr. K. Meenakshi. So over to Dr. Deepak Padmanabhan to take over the session, introduce, and carry on the session. And welcome all of you.
Thank you, Dr. Ulhas, for this opportunity. I'd like this opportunity to also welcome Dr. Madhavan here to our CSI Rhythm Summit. Less said, I don't need to speak too much about Dr. Madhavan introducing her, but as you shall ascertain during the course of this talk, she has an innate ability to make the most complex things very simple. Without further ado, I invite her to take charge of this topic for drug therapy for long QT syndrome, following Dr. Shah's extremely cool case. Thank you.
Thank you, Deepak, and thank you, Dr. Pandurangi. Can everyone hear me okay?
Yes, very clear.
Okay, perfect. Thank you. And really appreciate the opportunity to be here. I actually miss being in Chennai this year. I hope everybody, all our colleagues and their family are safe in these trying times. So Dr. Pandurangi wanted me to talk about drug therapy for long QT syndrome. And I just want to give a disclosure up front that I'm an adult cardiologist. I'm an adult electrophysiologist. So I'm going to come at it from the standpoint of what I see in my clinic every day. And hopefully some of this will be useful to you. And the other thing he told me when he first contacted me was to talk about some of the mechanisms behind why we choose some of these drugs. So we'll spend a little bit of time talking about that as well. So these are the diagnostic criteria. I'm not going to really go into details of this. We'll skip over this because I'm sure everybody is familiar. We all know that there are multiple genes now identified for long QT syndrome, but as Dr. Shah mentioned, the majority of cases are due to 3 genes. The first one is the LQT1 syndrome, which is the potassium channel mutation in the IKS channel. The second one, LQT2, is IKR potassium channel mutation. Both of these are loss of function mutations. And then the LQT3, which is the cardiac sodium channel mutation in SCN5A. So we'll keep that in mind and talk a little bit about the ion channel physiology here. I'm not going to go into too much detail, but just highlight certain things for why we choose certain drugs for these conditions. So when we think about the action potential, there are inward currents and outward currents. So there is the inward current through the sodium channel and then the calcium channel later in the action potential that lead to the depolarization. And then the repolarization is due to the outward current, the potassium currents. So anytime you have a loss of function mutation in the potassium channels, you're going to have prolongation of the repolarization. And anytime you have a gain of function mutation in the sodium channels, you're going to have a prolongation of the repolarization and the action potential duration. But more important than the prolongation of the action potential duration itself is the fact that the prolongation doesn't occur in a uniform fashion throughout the ventricles. So there is usually greater prolongation in the M cells compared to the epicardial and the endocardial myocardium, and hence there is dispersion of repolarization throughout the myocardium. And the dispersion of repolarization is really what is most responsible for any EAD propagating and leading to the torsades. So the genotype is the ion channel issues, and then the phenotype of torsades happens because of the QT prolongation and the dispersion of repolarization. We'll keep that in mind for now. Another concept to keep in mind when we think about the ion channels is really the role of the sodium channel and the late sodium current in these disorders. So in any heart, the sodium channel is going to be in 3 different states. At the beginning of the action potential, it's in a closed state. In phase 0, there is rapid opening of the sodium channels, which lasts only a very brief period of time. And then in normal hearts, there is rapid inactivation of the sodium channel. And there are only a few sodium channels that remain active later in the action potential, leading to the late sodium current. So the late sodium current in normal hearts is a small current, and it is really overshadowed by the potassium current during repolarization phase. Now, what happens when there is an abnormality of the sodium channel? When there's an abnormality of the sodium channel, this late sodium current can be exacerbated. So that can happen either because the open channels don't go to an inactivated state quickly, or it can happen because the channel reopens in a repetitive fashion. But the net effect is that there is an increase in the late sodium current. And this is really a key factor for why patients with long QT3 syndrome have torsades. We look at why that is. Another emerging data shows that the late sodium current is also important in the long QT2 syndrome patients that basically have a HERG mutation. And they are even more important in some patients who have drug-induced long QT syndrome, which may be something that adult cardiologists see even more frequently than the genetic long QT syndromes. So there is an important role for late sodium current in all of these conditions. So what happens if the late sodium current is increased? This is a very nice set of modeling experiments performed in a patient with a SCN5A mutation. The top panel here, I don't know if you can see my arrow here. I hope you do. The top panel here basically shows the action potential duration if there is no late sodium current. And the bottom panel shows if there is an increase in the late sodium current. So if there's an increase in the late sodium current, you can see that the action potential duration actually increases in all layers of the myocardium, but the increase is more pronounced in the M cells and less pronounced in the endo and the epi cells. So again, this leads to not only a prolongation of the QT interval, but also that dispersion of repolarization that we talked about. So we'll keep that in mind. As we go through the different drugs, we'll see why those drugs are effective in long QT syndrome. And a lot of this has to do with the late sodium current. So with that in mind, we'll move over to the clinical aspects, the bread and butter of treating long QT syndrome patients with drugs. So beta blockers are really the cornerstone for treatment of long QT syndrome. And this is kind of the recommendation from the guidelines, but the thing to keep in mind is if you have a patient diagnosed with a genetic long QT syndrome, there is an indication for a beta blocker. Just the level of evidence for that indication is highest if the patient has already been symptomatic. And it's also higher if the patient has a really long QT interval over 470 milliseconds or even over 500 particularly. But even if you have an asymptomatic individual who has a genotype positive, or has a phenotype positive with a shorter QT interval, you still should be considering treating those patients with a beta blocker prophylactically. So we all know that the genotype plays a huge role in management of long QT syndrome. This is old data based on natural history of long QT syndrome that showed that LQT1 patients have the best prognosis. LQT2 patients and 3 patients tend to have little worse prognosis. And corresponding to this, when we look at the risk reduction for arrhythmic events, whether it's syncope or sudden cardiac death, the risk reduction with beta blockers is the greatest for LQT1 patients. It works the best for LQT1 patients. In fact, it works so well that most of these patients do not require an ICD. So 90 to 95% risk reduction in patients with long QT1 syndrome. But that's not to say that there is no risk reduction in 2 and 3. So patients with LQT2 and LQT3 tend to have about an 80% risk reduction, which still is quite significant. So despite early concerns about whether to treat LQT3 patients with beta blockers or not, I can tell you that the beta blockers are really the cornerstone for all 3 major types of LQT3 syndrome. And really the next question is, how do beta blockers work? Beta blockers don't work on the potassium channels, which are really the main problem here. But beta blockers work predominantly by reducing the adrenergic drive. They reduce the peak heart rate during exercise, and there is shortening of QT interval, but this is more prominent during exercise. And it's really important to remember that beta blockers actually reduce the dispersion of the repolarization that we talked about. And this is most prominent during exercise. And obviously, exercise is a major trigger for LQT1. So you can imagine how this can be useful dominantly in LQT1 patients. So this is a nice small study in LQT1 patients that looked at what happens to QT interval during exercise before beta blockers here and after beta blockers in the second column here. So there is clearly a reduction in the QT interval with exercise at matched heart rates. And importantly, there is actually a reduction in the features in the ECG that represent dispersion of repolarization after a person is started on beta blockers. So this is an important mechanism by which beta blockers help in this condition. Now that we have kind of established that beta blockers are important and really are the main treatment, now the next question is what kind of beta blocker to use. And I don't think this is a controversy anymore at all. There's been a ton of data over the course of the last 10 years. This is one of the earlier studies that looked at predominantly type 1 and type 2 long QT. And they showed that the non-selective beta blockers, propranolol and nadolol, have a much lower risk for syncope, arrhythmic syncope, compared to the selective beta blockers, metoprolol. So this is one of the earlier studies, and this has been followed up by even larger studies. This is from Dr. Arthur Moss, where they went a step further and looked at, what about the genotype? So when you look at LQT1, and remember, it's really the LQT1 patients who get the most benefit out of a beta blocker. When you look at those patients, still the non-selective beta blockers here, the propranolol and the nadolol, tend to be the most effective. But atenolol still has some effect. So in LQT1 patients, the preference is still the non-selective ones, but maybe the other ones will have some effect. But if you look at the LQT2 patients, it's really nadolol is the only one that produces sufficient risk reduction. So, and this was followed up more recently from Dr. Sylvia Priory's group, where they looked at 1,700 patients with long QT syndrome, predominantly 1, 2, and 3. And again, nadolol was the only drug that produced sufficient risk reduction. Propranolol was non-significant in the study, and importantly, the non-selective ones, predominantly metoprolol, is pretty much not helpful in this condition. So keep in mind the dominant treatment is beta blockers, and the beta blockers of choice are nadolol, followed closely by propranolol. So the question is why the differential effect? When we think about why we pick these drugs, why do we pick the non-selective beta blockers over the selective beta blockers? Part of it comes from clinical experience. The centers of excellence have used nadolol predominantly and found it to be useful, like I showed you in the last 3 slides. But there is some, basis in ion channel physiology for this as well. We know from studies that propranolol, apart from being a beta blocker, also has some sodium channel blocking effects. It has a sodium channel blocking effect both on the peak sodium current and the late sodium current. And in fact, in this study, looking at the differential effect on peak versus late sodium current, the propranolol drug has an even greater effect on the late sodium current, which is the current, as we looked at, should be blocked, right? So that's one of the reasons why propranolol may be more effective than the selective beta blockers, because metoprolol and atenolol do not have the sodium channel blocking effect. Now, how about nadolol? Nadolol has some effect on blocking the peak sodium current, but not really the late sodium current. So we'll keep that in mind. And as we look at how to treat these patients, as I said, nadolol is really the top choice. But in LQT3 syndrome patients, there may be a preferential role for propranolol because of its effect on the late sodium current. So keep in mind propranolol and nadolol. So to summarize kind of the Mayo of LQT clinic approach to treating these patients, beta blockers are the cornerstone for managing these patients. And that applies even to the LQT3 patients. That's the first drug that you want to try. Nadolol and propranolol are preferred. We don't want to use atenolol and metoprolol and the other selective beta blockers. And then I have the doses here, the typical doses used. You can, and this is a very nice summary from Dr. Ackerman, who's our expert here and one of world's expert in this condition. So a nice read for you if you want to go home and read something. And it's really important to keep in mind that while beta blockers are important, we cannot really start these patients at a super high dose initially. And that only leads to intolerances. That's a good way to say that a person is not tolerant to beta blockers, right? So you always want to start slow and up titrate the beta blocker. And this is particularly true for the asymptomatic patients and the mildly symptomatic patients that you see in an outpatient
Excuse
setting.
me, ma'am. I'm extremely sorry for the interruption, ma'am. 2 minutes of the screen time left. Thank you.
Well, I'll try to do my best. We are kind of halfway through.
No, Malini, I think, you can take another 5-8 minutes, please. You can carry on.
Okay. So that's the beta blockers. I'll try to hurry this up. So the sodium channel blockers are the main drugs that you think about when you think about adjuvant medical therapy. And mexiletine is predominantly the sodium channel blocker that's in use. You saw in that very nice case from Dr. Shah how the patient was eventually treated with propranolol and a combination with mexiletine. So the most data for mexiletine exists in the long QT3 patients. This was one of the earlier data that showed that patients with long QT3 syndrome have a reduction in the QT interval when treated with mexiletine. And that corresponds to a reduction in the arrhythmic episodes that happen in these patients. And very nice ECGs here from the same study that show that you have the typical genotypic manifestation of long QT3, and there is a reduction in the QT interval following mexiletine therapy. So how about the other sodium channel blockers? So mexiletine has an effect on both the peak sodium current and the late sodium current. But the predominant effect of mexiletine is to shorten the action potential duration. It doesn't affect the slope of phase 0 like flecainide does. So clearly from a mechanistic standpoint, mexiletine should have an advantage, and it's really the top sodium channel blocker that is being used for this condition. Flecainide could be used, but it's not a preferred sodium channel blocker. The other one that can be probably thought of as a second line after mexiletine is ranolazine, because ranolazine has a specific sodium channel late current blocking effect. So mexiletine, ranolazine, and then flecainide. And the current recommendations say that you can think about a sodium channel blocker as an add-on therapy. Remember, it's add-on top of the beta blocker. for patients who have a persistent elevated QT interval over 500 milliseconds. And it's really important to look for the acute effect in shortening the QT interval. A good responder to mexiletine is going to have at least a 40 millisecond reduction in QT interval after the first or the second dose. Now, Dr. Shah showed a little bit of this data already, but I'll go into some of the details. So mexiletine is helpful in long QT3 clearly, but emerging data shows that it can be helpful in long QT2 also. That goes back to our initial discussion about the late sodium current and its role in any long QT disorder that involves the hERG protein. So whether it's congenital type 2 long QT syndrome, or whether it's drug-induced acquired long QT, both of those conditions, there may be a role for mexiletine because of its late sodium channel blocking effect. So this is multi-center data headed by Dr. Ackerman, where they showed that there is indeed a reduction in the QT interval, acute mexiletine therapy, in a lot of patients with LQT2 syndrome. Not everyone is a responder, so that's important to keep in mind and important to assess whether your patient is a responder or not. And it can be thought of as an adjuvant therapy to beta blockers. And again, similarly, from the same study, this shows the shortening of the QT interval in LQT2. And then I would like to finally kind of end with the other adjuvant therapy that is thought about periodically in LQT2 patients, because there is some older data which would be potassium supplementation for the hERG mutations, and you can supplement potassium orally or use it. Or use a potassium-sparing diuretic like spironolactone. So this older data showed that there is indeed a reduction in the QT interval with potassium supplementation. And from the same paper, you can see that there is potassium levels that are lower here, 3.7. Higher potassium levels lead to a much shorter QT interval and a more normal-looking QT interval. So think about potassium supplementation as an adjuvant if other things aren't working for you. I would be remiss if I don't mention the role of ICDs and also the left cardiac sympathectomy. So the main take-home point here is, one, beta blockers are indicated and they're the cornerstone for treatment. And if there is a second take-home point from this talk, I would like you to remember that LQT syndrome diagnosis does not equal to an ICD. That's really important to keep in mind. In fact, the vast majority of these patients can be managed without an ICD. So when should you think about an ICD? The clearest indication is secondary prevention ICDs. If there is a prior cardiac arrest, you think about an ICD. If a patient has recurrent arrhythmic syncope with being intolerant to beta blockers or with being on adequate doses of beta blockers, then you think about an ICD. But the vast majority of LQT1 patients can actually be treated without an ICD as long as they have not had out-of-hospital cardiac arrest that needed resuscitation. So left cardiac sympathetic denervation, we already touched upon this. I'm not going to go into details of this and how it is done, but always think about it as an adjuvant to beta blockers in all of the LQT syndrome patients. And certainly the most data exists for the LQT1 syndrome patients, such that if you can combine a beta blocker with sympathectomy, you can pretty much avoid ICDs in the majority of these patients. So I leave you with this kind of summary slide to go over. I won't look through all of this, but I do want to emphasize, when do you think about primary prevention ICDs? We talked about how it is rarely required in LQT1. In LQT2 and 3, there may be a greater indication for primary prevention ICD, but still the majority of these patients can also be managed without an ICD. So when do you think about a primary prevention ICD in LQT2 and 3? It's if you have a patient who has a persistently elevated QTC greater than 500 milliseconds, and particularly true for women, because women tend to be at higher risk for sudden death compared to men in these conditions. So think about a primary prevention ICD in those situations, but not necessarily in every single patient with LQT2 and 3. So I think I'll stop there with that and open it up for discussions.
Thank you, Malini, for an excellent overview of the mechanistics of the way drugs work, as well as touch upon additional adjuvant drugs that we could potentially use in tricky situations. I have a couple of questions before you. One of them would be whether you do diagnose and treat LQT only on the basis of the physiological manifestation on the ECG, or do the same recommendations hold if you are diagnosing it on the basis of a genotype?
So there is certainly, in some patients, there is certainly discordance between the genotype and the phenotype. So a number of these studies coming out of the large registries do base things on the genotype. But if you're in a resource limited setting where the phenotype is clearly a LQT2, it is certainly reasonable to base your treatment on that.
Dr. Shomu once had a query. He wants to ask, is there a target heart rate that you want to achieve when attempting management with beta blockers?
Say that again. Is there a particular heart rate target?
That you're
So the target is what would be the maximum tolerated dose of beta blockers. So more than the heart rate during rest or exercise, we are looking at what is tolerated. And then, I had those data for how much is kind of average per kilogram. It's per kilogram because a lot of these studies do come from children. So what we are looking for is how much can we titrate it up based on the tolerance.
Dr. Tachel wants to know what is the current role of the adrenaline provocation test in diagnosis, and perhaps looking at how you could look at it as a response to therapy, perhaps,
So the adrenaline diagnosis test, we typically use it for as an adjuvant to exercise test. I do think the exercise test is more informative than doing an adrenaline test, but we do use it, particularly in patients who cannot exercise, which is rare in the LQT population, but it can be used as an adjuvant. And it can certainly provide differentiation between LQT1 and LQT2 phenotype too, so that it can be useful in that regard as well. Now, after you start a beta blocker, certainly reasonable to repeat that the exercise stress test. I'm not aware of data for repeating the adrenaline test after starting beta blockers. Maybe Dr. Shah can weigh into this, but if you start a beta blocker and titrate it up, repeating the exercise stress test can be very helpful.
Yeah, we don't use adrenaline provocation anymore. We just use exercise stress testing. And just as you said, after titrating the beta blocker, we would repeat the stress test. In children, we typically aim for 10 to 15% of a reduction in the maximum heart rate with exercise, as long as they also tolerate that dose.
Dr. Suchita has a question as to he's wondering whether ICD is harmful in a patient of LQTS, where shocks can work as an adrenergic stimulus to cause more TDP.
Very much so. That's extremely important. Excellent point to make. That's really the reason why we should be extra careful about putting ICDs in long QT syndrome patients. There should be a really good indication for it. There are certainly other genotypes that are rarer that we haven't talked about, with a much higher risk for sudden death, where we should be pulling the trigger for ICDs earlier. But for the three major genotypes, we do have to be careful. There is a high risk for complications with ICDs in these patients. They come in the form of infections, lead failures, and very importantly, what Dr. Pointed out is once they get a single shock, there is an adrenergic drive. And then it's just, going down the rabbit hole. There's going to be more adrenergic drive, more torsades. and a VF storm after that. So it's really important that even if you give these patients an ICD, the other medical therapy has to be maximized. And if they ever present with a VF storm, treatment is, whether they're a child or an adult, is along the lines of what Dr. Shah showed in that really dramatic case. They need to be sedated, completely paralyzed, immediate sympathetic denervation. Initially, we typically do that with bupivacaine injection to tide them over until we can get them ready for the OR. And certainly beta blockers given IV at that stage would all be important.
Question, and if I can take that on to, is Dr. Tachel's question as to what and how would be the way you would titrate mexiletine and flecainide? Would you directly start at a high dose, low dose? How would the initiation of the drug be for both of those drugs?
So mexiletine, the dose used in these studies that are published right now is along the, I think, about 8 milligram per kilogram. And mexiletine can be started at perhaps close to the maximum dose and then titrated up. But beta blockers, you want to start low unless you're really in a bind with the active torsades happening, in which case you want to start high. So mexiletine can be started at near the dose that you want to use, and then you want to assess for the response.
Is it the same for flecainide too?
I haven't used flecainide for long QT, so I'm not sure I can speak in an informed way about that. Dr. Shah, have you used flecainide for it, and how do you do it?
We don't use flecainide. I think flecainide, you have to be careful because it does have a proarrhythmic potential. Right. So we have gone, just as you said, we start mexiletine at about 7 to 8 milligrams per kilo per day. But in order to achieve QTC shortening, which indirectly reduces your risk for torsade, we've had to go as high as 12 to 14 milligrams per kilo per day. Just know that mexiletine can lower your threshold for seizures. So we typically, if we go over 10 milligrams per kilo per day, we monitor serum drug levels. And we've had at least 2 patients who had seizures on mexiletine. So just keep that in mind.
Sure. Dr. Sivkumar, Dr. Meenakshi?
Actually, Dr. Deepak, thanks for taking the entire session nicely. Dr. Malini, it was an amazing presentation. I'm far away from electrophysiology, but I could get 2 very simple messages for a practicing non-electrophysiology person. Give propranolol instead of metoprolol. Wonderful message. Check potassium levels once, and if the patient is having low potassium levels, give potassium or spironolactone. These, I think, for a non-electrophysiologist, these are some extremely useful messages. There are quite a lot of cardiologists who are not electrophysiologists who will give metoprolol because of the longer duration of action rather than giving propranolol. And you have just hit the message very clearly. I think it was an amazing talk. I enjoyed.
Thank you. Thank you, Dr. Shivkumar.
Dr. Meenakshi, please.
Thank you, Dr. Malini. That was a very enlightening talk.
Thank you.
Especially for a non-electrophysiologist.
So Deepak, thank you for taking the session over so very nicely. Shiva, thank you very much. Meenakshi and Dr. Malini. Well, we missed you this year, but then this was again amazing. We always look forward to your continuous support to our EP program. So, ladies and gentlemen, that comes to an end of the 3rd day of this 6 days sessions of Cardiac Rhythm Council. And everybody, on behalf of Cardiological Society of India, I thank everyone, the audience here who participated so very interactively, all the distinguished speakers and the moderators. And I would like to say that it's such a gratifying day today. There were 850 registrants for the day today, and there are more than 300 people who are active onto today's session. I think it is one of the largest numbers. So it gives us so much of happiness to all our team members here sitting since morning today. All right, so thank you everyone, and good evening and good night. And Dr. Malini, have a great day.
Thank you. Thank you very much. Thanks to everyone. Nice to see some familiar faces. Thank you.
Only have
Thank
a
you
great
all.
day. Have a great day.
Take care. Thank you, everyone.
Take care. Yep.
Thank you, Shoma sir.
Take care.
Thanks, Ullas sir.